Namaste everyone. Today I am presenting about the cortical bone trajectory as an alternative to the traditional pedicle screws for thoraco-lumbar injury. Ideal spine instrumentation technique should provide the stable construct. It must have a lesser risk to the neurovascular injury. At the same time, it must also have a lesser soft tissue injury and the minimal blood loss, and as far as possible, shorter operative time. Spine instrumentation started in 1948 with the transfacetal screws, and over the time it has progressed a lot from external fixation to the spine instrumentation to the internal fixation for the spine. In fact, Roy Camel popularized the technique of spinal instrumentation using the pedicle anatomy. He used the various designed plate designed by himself and also used the hooks for the spine instrumentation. Traditional pedicle screws, most of the time with what we are using today, are fixed into the cancellous bone in both in the axial plane and also in the sagittal plane. They are mainly placed into the cancellous bone. And they are placed in the conversion trajectory. And if you miss the medial wall of the pedicle or your trajectory angulation is more, then they can enter into the spinal canal, causing injury to the spinal cord or the neural structures. Since you are putting the screws in the convergent way, you need to dissect or strip the muscles far lateral from the midline and causing the large amount of the muscle damage. And you are putting the screws lateral to the facet joints because your entry point is lateral to the facet joints, which is richly supplied by the arteries. And hence, when you dissect the muscles around the facet joints, there can be an increased amount of the blood loss. So, can we use the cortical bone of the vertebra for the fixation instead of cancellous bone? Does it have a lesser risk of neurovascular injury? Does it have a lesser chance of the tissue dissections or the muscle stripping? And does it cause a lesser blood supply? So, if you have to answer the questions of all these possibilities, then the next alternative can be a cortical bone trajectory. Cortical bone trajectory was defined by Santoni et al. In 2009 as a novel thoraco-lumbar pedicle screw trajectory for the lumbar pedicle screws, and it was commonly used for the osteoporotic vertebra. In cortical bone trajectory, the direction of the screw in the sagittal plane is from caudocranial, as shown in the figure A, and it is a divergent as shown in the figure B, as compared to the craniocaudal directions in the traditional pedicle screw and the convergent direction in the traditional pedicle screws. If you look at the Hounsfield unit of the various structures of the traditional pedicle screws trajectory and the cortical bone trajectories Hounsfield unit, you can very clearly see that the Hounsfield unit of the cortical bone trajectories are much superior than the Hounsfield unit of traditional pedicle screws, as shown in the axial CT scan in the CBT and the traditional pedicle screw or the TPS trajectory. If you look at the cut section of the vertebra also, in the traditional pedicle screws placement, there are lots of cancellous bone except at the level of the pedicle, whereas in the cortical bone trajectories, there are lots of cortical bones in the trajectory of the cortical bone trajectory screws. Biomechanically also, it has been found that cortical bone trajectory screws has a better results than the traditional pedicle screws. The pull-out strength and the stability of the cortical bone trajectories are found to be 30% higher than the traditional pedicle screws. As shown in this slide, there is a 367 newtons are required to pull out the screws which has been placed in the cortical bone trajectory, as compared to 288 newtons for the screws which has been placed in the traditional pedicle screws trajectory. And even in the finite element models, reveal that pull out the resistance produced by the screws over the bone is much higher in the cortical bone trajectory, as shown in the red area in the sagittal and the axial plane. The red areas shown in the cortical bone trajectories are at the beginning of the pedicle, at the level of the pedicle, and even it is seen at the tip and within the vertebral body. Whereas in the traditional pedicle screws, the red areas are seen only at the beginning or the entry point and the pedicle, not in the tip of the pedicle screw or within the vertebral body. Even the insertional torque has been found to be superior in the cortical bone trajectory as compared to the traditional pedicle screws, which is about 1.7-fold more. Matsukawa et al. Studied the insertional torque of the cortical bone trajectory and traditional pedicle screws within the same vertebra and found that cortical bone trajectories are superior than the traditional pedicle screws. The real-life applicability also studied in vitro by testing the 2 millimeter displacement, that is also known as the toggle test, which mimics the bending, axial rotation and flexion and rotation, and it has been found that much higher cycles are required. Around 184 cycles are required for the 2 millimeter displacement for cortical bone trajectory, whereas 102 cycles is enough for 2 millimeter displacement in traditional pedicle screws. So what it clearly shows that cortical bone trajectories in fact tolerate much more bending stresses than the traditional pedicle screw. And clinically also this is very obvious. Since you are putting the screws in the convergent way in the traditional pedicle screws, you have to dissect the muscles much laterally from the midline, whereas the dissection in the cortical bone trajectory is limited within or around 2 to 3 centimeters from the midline. And it causes a less muscle injury, at the same time less blood supply. Hoffman et al. Found that the blood supply in the cortical bone trajectory is around 200 ml as compared to 413 ml in the traditional pedicle screws, and which is statistically significant. They found shorter operative time for the cortical bone trajectory as compared to the traditional pedicle screws, but that was not statistically significant. And they studied these findings. They recorded this finding in the various level of leaf. Little bit about the surgical technique. First, we need to get the orthogonal view of the spine in anterior posterior view. Then we delineate the outer border of the pedicle in anterior posterior view. Then we draw the vertical line lateral to the medial to the outline of the pedicle, and the horizontal line at the inferior border of the pedicle outline. The point which intersect this vertical and the horizontal line is the starting point for the cortical bone trajectory. Suppose you are putting the cortical bone trajectory on the right side when the patient is in prone position, then the number one shows the starting point for the cortical bone trajectory. And if it is on the right side, now your trajectory will direct towards 1 o'clock. If you think that the outline of pedicle is a clock, and starting point will be 7 o'clock, and your trajectory will be towards the 1 o'clock, and this is in the coronal plane. If you look at the lateral view or in the sagittal plane, you have to target the posterior 1/3 of superior end plate. So this is the technique of the putting the cortical bone trajectory. And similarly, if it is on the left side, then the trajectory will be from 5 o'clock to 11 o'clock. And in the lateral view, again, it is the same, that you have to direct posterior 1/3 of the superior end plate of the vertebra. And this is a per-operative picture where I'm trying to put the cortical bone trajectory screws on the right side. You can see that the direction of the screw will be from 7 to 1 o'clock, which is represented by the filler in the per-operative picture. This is the per-operative fluoroscopic picture of the same case. You can see that the screws are in the divergent way in the coronal plane and in AP view, and it is caudocranially directed in the lateral view. In the per-operative picture, you can notice that the screws and the rods are very near to the midline, and there is much less soft tissue dissection. This is the post-operative picture of the same patients. Again, you can appreciate the direction of the screws. In the sagittal plane, this is the caudocranial, and in the axial plane, this is a divergent, and I'm using the cortical area of the bone for the fixation of the screws. We slightly modified the Santoni's technique of cortical bone trajectories. Instead of divergent screws, we tried to put the screws in the parallel way, as shown in the figure B. The red lines indicates the Santoni's technique of putting the cortical bone trajectory in divergent way. So we modified this technique, putting the screws in the parallel. So that means instead of oblique screw placement, we are putting the screws directly caudocranial directions without conversion and without divergence. So instead of 7 to 11 or 7 to 1 or 5 to 11, we're all putting all screws in 6 to 12 o'clock positions. Again, our starting point in the sagittal plane is slightly cranial, so that we can target posterior 2/3 instead of posterior 1/3. We are targeting now posterior 2/3 of superior implant, so that you can put the longer pedicle screws. So what is the our technique? So again, we get the anterior posterior view of the spine, orthogonal anterior posterior view of the spine, and we delineate the outer border of the pedicle. Then instead of going lateral or medial to this pedicle outline, we just bisect it at the middle for the vertical line, and for the horizontal line, again the similar line at the inferior border of the pedicle. So intersection of these two lines now becomes the starting point. So instead of making the oblique trajectory, we make the trajectory straight upward. So that means instead of oblique 7 to 1 or 5 to 11, we now target from 6 to 12 o'clock positions. So again, this is a comparison between the CBT technique of Santoni's and the our modifications. Santoni's technique is 5 to 11 o'clock, whereas our technique both on the right and left side is 6 to 12 o'clock positions. The advantage, as we have proposed, that we can put the longer pedicle screws in our modifications. This is an example of 50 years old female with the L1 burst fractures, where we have put the cortical bone trajectory screws with our modifications, and you can see that we are not divergent. We are putting the screws in parallel way from 6 to 12 o'clock positions. So what are the proposed advantages of our modification of cortical bone trajectories? You can see that it is easy to locate the landmarks when you have a straight landmark instead of the oblique landmarks. In Santoni's technique, landmarks are oblique, but in our modifications it is vertical. So instead of 7 to 1 or 5 to 11, our modifications says it is 6 to 12, both in right and left side. And obviously it retains all the benefits of the cortical bone trajectories described by Santoni. It has also lesser muscle stripping. It has also lesser blood supply, lesser blood loss. And biomechanically also, when you are able to put the longer pedicle screws into the vertebral body, it has been found that it has a lower incidence of the fatigue failure. And we also studied the literature about the parallel or the angle screws, and we found that there is a greater pull-out strength and a better fatigue performance in the parallel screw than in the convergent pedicle screws. And the graph also in the slide shows that all the damages are less in the parallel screws as compared to the angle screws, which has been found in the biomechanical studies. We compared the Hounsfield unit of 550 lumbar vertebra for the traditional pedicle screw track, cortical bone trajectory screw track defined by the Santoni, and our modification, and we found that our modification is in between the traditional pedicle screws and the cortical bone trajectory screws defined by the Santonis. Since our technique, we feel that is easier than the Santoni's technique, and it has a much higher Hounsfield unit than the traditional pedicle screw. So we propose that our modification of the cortical bone trajectories is also better than the traditional pedicle screws. We started putting the cortical bone trajectory screws percutaneously. Both the technique described by Santoni and the modified technique of ours can be used percutaneously, resulting the less soft tissue damage. This is an example of the cortical bone trajectory screws fixed percutaneously, and you can see that the screws are parallel. We studied about the 29 patients of the thoraco-lumbar injury of in between August 2020 to July 2021, and altogether we put 192 screws in different level from D11 to the L3, and we could successfully put the screws, both our modification and the Santoni's technique, and there are very less complications. In some cases we found the medial cortex breach, And as obviously these screws cannot be put in all the cases. If you have a parts fracture or if the parts are very thin, then the screws cannot be kept with the Santonis technique, and in those cases we put the screws in the traditional pedicle screws technique. This is again the example of 53 years male with a D10, D11 fracture dislocations, which was fixed with the cortical bone trajectory screws technique. This is another case of the L1 fracture, where you can see that the spine has been fixed both anteriorly and as well as posteriorly, and posteriorly it was fixed with the our modification of cortical bone trajectory, and you can see that around 5 to 6 centimeter incision is enough to put the screws at the 3 level of the spine. So take home message: cortical bone trajectory screws, both described by Santonis and our modification, are feasible alternatives of traditional pedicle screws for thoracolumbar spine injury. It has a better biomechanical advantage, and it has also clinically, it has a lesser tissue injuries and lesser blood supply. I thank you for your kindness.